In this lecture on the esophagus, what we're going to do is cover some high-yield topics that you need to know for general surgery. There's a lot more you need to know about the esophagus and stomach in general, which you can look at in the GI videos in medicine. But if what you're doing is studying only for the shelf for surgery, this should be sufficient. The first disease we're going to talk about actually has very little to do with surgery at all, but it's so prevalent that everyone should know about it, and you're likely to get a question on it anyway. That's reflux. GERD is caused by a weakened LES. An LES is the lower esophageal sphincter. Its whole purpose is to prevent the reflux of acid into the esophagus. Esophagus doesn't like that acid. It's not designed to handle it. So when the LES is weakened, there is acid reflux, and the esophagus gets burned. And that's what the patient is primarily going to complain about. The symptoms of GERD are retrosternal burning chest pain that is made worse by laying flat and by eating things that are spicy, and made better by sitting up, and antacids. Antacids turn off the pH, and the pH is what's doing the damage. Now, there might be a case, though, where you see not retrosternal burning chest pain with a metallic taste in the back of the mouth, but instead you see nocturnal asthma. And nocturnal asthma is not someone who has asthma, but someone who gets up in the middle of the night and is wheezing and coughing and hacking, but it only happens at night. That's because they're laying flat on their back. Acid is coming out of the stomach and actually burns the larynx. So nocturnal asthma or that retrosternal burning chest pain makes you think of GERD. The diagnosis is made if there are no alarm symptoms. We'll talk about what that means in a minute. With lifestyle and PPI, there's no diagnostic step. Proton pump inhibitors are going to increase the pH of the stomach so it burns less. And lifestyle modifications are going to be things like avoiding coffee, peppermint, chocolate, and alcohol, as well as elevating the head of the bed at night. Now, those lifestyle modifications aren't going to fix the GERD, not fix the pathology, they just make the symptoms better. But if there are alarm symptoms, or there's a failure of the lifestyle and PPI after 4 to 6 weeks, now you've got to do the EGD with biopsy. And you do this EGD with biopsy to make sure there's no cancer. So the symptoms that are going to be the alarm symptoms that push you right to endoscopy: nausea, vomiting, weight loss, anemia. Things that might push you towards cancer, that's when you go to biopsy first. But if all they have is GERD, that is, they got better with lifestyle and PPI, you can continue to treat with PPIs. But the problem with GERD, as we'll talk about in the cancer section coming up here, constant burning of the esophagus induces Barrett's metaplasia, where the esophagus turns into the small bowel. So this is going to be treated with high-dose PPI. Anytime somebody undergoes a metaplasia, that's a risk factor for cancer. That's pre-malignant. And so if they cross that line into dysplasia, not cancer yet, now you got to get rid of that tissue with ablation. And if they progress all the way into adenocarcinoma, the only thing you can do is resect. So look for the person who's got GERD, who then spontaneously gets better without PPIs. That's metaplasia. They're at risk for turning into cancer, so they need high-dose PPIs. Now, this whole time, none of this is surgery except for resection of a cancer. So surgery can be used to treat GERD by doing a Nissen fundoplication. This is where the surgeon literally wraps the stomach around itself, tightening the LES surgically. Before you do that, you want to make sure this person really has GERD, and that's the symptoms. The symptoms they're having are from that disease. So the best test, not the one you're going to order very often, but the best test for GERD is the 24-hour pH monitor. That is, the patient keeps a log of when they feel symptoms, and you correlate that with the pH of the esophagus. If indeed the pH is low and they have symptoms, it is from GERD, and you can consider surgery. But if you take this Nissen and you do it too tight, you create achalasia. That's the next disease, achalasia. The pathology here, it's absent Auerbach plexuses, and it can be caused by Chagas disease. But what I want you to remember, achalasia is caused by the LES that won't relax. It's the exact opposite of GERD. And so, if the LES doesn't open, when you swallow, food's going to get stuck. And that's what people complain about. They complain about a knot or a ball of food stuck at the gastroesophageal junction. It's going to be retrosternal, might even hurt. And when you say dysphagia, as we talk about in the medicine videos, the first diagnostic step is going to be a barium swallow. What you're going to see is the bird's beak esophagus. It's very tight down here, and all the barium is going to be in this dilated proximal esophagus. If you see that, the diagnosis is done. But the best test is going to be manometry. So if the question asks you, what's the diagnosis? If you see the barium radiograph, you're done. You know it's achalasia. But if they ask you what's the next step, it's manometry to confirm that it is the tight LES and everything else is functioning normally. And before you treat achalasia, you must do an endoscopy with biopsy to rule out pseudoachalasia, which is effectively cancer. If you're going to treat achalasia, you could use Botox. You have to do an endoscopy and inject the botulinum toxin, and it will cause relaxation. But it's temporary, so you'll have to go in every 6 months and do another endoscopy. That's generally reserved for people who are terrible surgical candidates, but somehow manage to be good endoscopy candidates. Dilation is not a bad idea because it's more permanent, but the risk of perforation is really high with dilation, and you'd have to repeatedly do it, so we don't do it. The best way to treat achalasia for all comers is going to be a myotomy, called the Heller myotomy, where you remove the muscle of the LES. You do it too much, you get GERD. Choose Botox or dilation when the person cannot handle a surgery and you can only do endoscopy. We mentioned a GERD, let's talk about cancer. In the esophagus, there's going to be two types of cancers. The first is in the upper third of the esophagus. It's squamous cell carcinoma, and it's generally brought on by drinking really hot liquids or smoking. It makes sense. The hot smoke, the hot liquids, the first place that touches is the upper esophagus. That's irritating. It leads to inflammation and then causes squamous cell carcinoma. The lower third of the esophagus is adeno. And adenocarcinoma is related to GERD. You don't treat it long enough, you get that metaplasia, dysplasia, and eventually it turns into adenocarcinoma. Now you've got a thing in the esophagus that's growing into the lumen. That is going to present with dysphagia. But the dysphagia is very specific. It is progressive. And because the thing is growing, you'll first have dysphagia to large substances, fluids like water, it can slip right by. But as it gets really big, you're going to get progressively worse, and smaller foods, and eventually water will have dysphagia too. So if you see that progressive dysphagia, the first step when working up dysphagia is the barium swallow. And what you're going to see is an asymmetric fungating mass, and to confirm the diagnosis, you do the endoscopy with biopsy. It's important to know that you don't go straight to biopsy, because if the tumor is high up and you put the endoscope in, you might perforate. So do the barium swallow first to confirm that there's something there, and then know where it is as you go in with the scope. If you find it after staging, the treatment is going to be resection. And lastly, the thing that gets compared a lot, especially on surgical rotations, is going to be Mallory-Weiss tear versus Boerhaave. Not because they're the same disease or present the same way, but because they both occur after vomiting. Mallory-Weiss is going to be a superficial tear in the mucosa of the esophagus. And because it's only superficial, it's going to be a self-limiting GI bleed. and it's going to be in someone that vomits as a weekend warrior. This is to say, the person goes out only on Saturday, drinks a bunch of beer, vomits a bunch of beer, vomits a bunch of beer, vomits blood, vomits bile. GI bleed happened and then it went away. No big deal. And because it goes away on its own, you don't have to do anything in the way of diagnosis or treatment. But the problem is, if someone's sitting there right in front of you and they're vomiting blood, you have no idea why. It might be an ulcer, it might be Mallory Weiss, you don't know. So if you see someone who's actively vomiting, you can't just assume Mallory Weiss tear. So what you have to do is treat them just like a GI bleed. 2 large bore IVs, IV fluids, having cross-transfused as needed, PPI, call GI. After the fact, if their hemoglobin doesn't change and they stop vomiting on their own and there's no more bleeding, then it might be worth saying it's Mallory Weiss. But only if someone has come to you and said, I did that previously, can you say, okay, it's Mallory Weiss. They're bleeding in front of you, treat them like any GI bleed. But in the vein of someone who's vomiting, who tears stuff, Boerhaave syndrome is way worse. Bin-Heating syndrome is a transmural tear. This is an esophageal perforation. The patient is going to be a career vomiter. But look for bulimia or alcoholism on the vignette. Because they've got a hole in their esophagus, they're going to have air in their mediastinum. This isn't like a contained pneumothorax. This isn't air in the lungs. It's crepitus throughout the entire chest. When they breathe, you'll feel and hear crepitus. Whenever there's a heartbeat, you'll hear the Hammond's crunch. It's the air around the pericardium. And they'll have mediastinitis, meaning they are sick as shit. They'll have fever, they'll have cough, they will be actively septic. The way the test is going to go is what you do in the way of diagnosis, because it's a little different than what you're used to. The first step is always a gastrographin swallow. If that's negative, then you do a barium swallow. If that's negative, then you do an endoscopy. And you don't progress unless the previous one is negative. Here's the logic. You're supposed to do a barium swallow because gastrographin is really irritating to the lungs, but it is not so irritating to the mediastinum. So that if it's positive and gastrographin leaks out into the mediastinum, you've confirmed your diagnosis with the least caustic material. Generally, we do a barium swallow because if you aspirate gastrographin, it's worse. But you're not worried about aspiration, you're worried about a hole in the esophagus. So first test is gastrographin. If that's negative, you go to the better test, barium, but it's more caustic to the mediastinum. If that's negative, only then do you go to the endoscopy because you don't want to put the endoscope into the chest. You like to stay in the esophagus. This is a surgical emergency. They go to the operating room immediately. All right, so high yield topics, not much to know, but this is what comes up on the test a lot in surgery. Got to know everything about GERD. It's going to be on every shelf and every subject. Achalasia, just remember the bird's beak and the myotomy is the way to go. Botulinum toxin only if they're not a surgical candidate. Cancer, upper third of the esophagus, squamous cell, lower third, adeno, lower third, GERD. Barium swallow first. And know the difference between Mallory Weiss, someone who vomits a lot and just happens to bleed a little bit, and Boerhaave's, someone who vomits a lot and tears a hole in their esophagus. That is esophagus.